The objective of the lecture: definition, circumstances, route of poisoning, important history point in poisoning and specific management, measures may be taken to prevent or decrease absorption, acetaminophen poisoning features and management, hydrocarbon poisoning features and management, caustic poisoning features and management, organophosphorus poisoning features and management, and prevention of poisoning. Definition of poisoning: it is exposure to chemicals or other agents that adversely affect functioning of an organism. Circumstances of exposure can be intentional, accidental, environmental, medicinal, or recreational. The route of exposure can be ingestion, injection, inhalation, or cutaneous exposure. We should know that all substances are poisons. The right dose separates poisoning from a remedy. Poisons can include prescription or over-the-counter medicines taken in doses that are too high, overdoses of illegal drugs, carbon monoxide from gas appliances, household products such as laundry powder or furniture polish, pesticides, indoor or outdoor plants, metals such as lead and mercury. The effect of poisoning range from short-term illness to brain damage, coma, and death. Almost all of these exposure in pediatric age groups, the preschool age children, are unintentional, reflect the propensity of young children to put virtually anything in their mouths. More than 90% of toxic exposure in children occur in the home, most involve only a single substance. Ingestion accounts for the vast majority of exposures. About 50% of cases involve non-drug substances, such as cosmetics, personal care items, cleaning solutions, plants, and foreign bodies. Analgesic topical preparation, cough and cold products, and vitamins are the most commonly reported pharmaceutical preparations. A second peak in pediatric exposures occurs in adolescence. Exposure in the adolescence age group are primarily intentional: suicide or abuse or misuse of substances, and thus often result in more severe toxicity. Approach to the poisoned patient. The initial approach to the patient with a witnessed or suspected poison should be no different than that in any other sick child, starting with stabilization and rapid assessment of the airway, breathing, circulation, and mental status. In any patient with altered mental status, a serum dextrose concentration should be obtained early and naloxone administration should be considered. A targeted history and physical examination serves as the foundation for the thoughtful differential diagnosis, which can then be further refined through laboratory testing and other diagnostic studies. That means we should suspect that the patient primarily may has hypoglycemia or opiate toxicity. Important history points. Obtaining an accurate problem-oriented history is of a paramount importance. Age of the child, toddler or adolescent, acute onset of symptoms without prodrome, sudden alteration of mental status, multiple system organ dysfunction, or high level of household stress should suggest a possible diagnosis of poisoning. Description of exposure. For household and workplace products, name, brand, generic, chemical, and the specific ingredient, along with their concentrations, can often be obtained from the labels. In the case of unknown exposure, clarifying where the child was found, for example, garage, kitchen, laundry room, bathroom, backyard, workplace, can help to generate list of potential toxins. Next, it is important to clarify the timing of the ingestion and to obtain some estimate of how much of the substance was ingested. It is better to overestimate the amount ingested to prepare for the worst case scenario. Past medical history, underlying disease can make a child more susceptible to the effect of toxin. Concurrent drug therapy can also increase susceptibility because certain drugs may interact with the toxin. A history of psychiatric illness can make patients more prone to substance abuse, misuse, intentional ingestions, and polypharmacy complications. Social history. Understanding the child's social environment helps to identify potential sources of exposures. Caregivers, visitors, grandparents, recent parties, or social gatherings. Environmental stressors, for example, new babies, parents' illness, financial stress that might have contributed to the ingestion. Unfortunately, some poisonings occur in the setting of serious neglect or intentional abuse. Physical examination. A targeted physical exam is important to identifying the potential toxin and assessing the severity of the exposure, assessing and stabilizing the airway, breathing, circulation, and mental status. Once one has ensured that the airway is secure and the patient is stable from a cardiopulmonary standpoint, a more extensive physical exam can help to identify characteristics of specific toxins or classes of toxins. In the poisoned patient, the key features of the physical exams are the vital signs, mental status, pupil size or activity, nystagmus, skin, bowel sounds, and odor. These findings might suggest a toxidrome that can guide the differential diagnosis and initial management. Toxidrome, it means, is a syndrome caused by a dangerous level of toxins in the body. It is often the consequence of a drug overdose. A systemic infection may also lead to a toxidrome. As we see, the clinical features of poison tachypnea occur in aspirin, carbon monoxide, bradypnea in opiate or alcohol, hypertension in amphetamine, cocaine, hypotension in tricyclic antidepressant, beta blockers, iron secondary to shock, convulsion occur in tricyclic organophosphorus, tachycardia in cocaine, antidepressant, amphetamine, bradycardia in beta blocker, large pupil in tricyclic, cocaine, cannabis, amphetamine, small pupil in opiate and organophosphorus. Laboratory evaluation, quantitative blood concentrations for selected intoxications, for example, salicylate, some anticonvulsants, and acetaminophen, iron, digoxin, methanol, lithium, ethylene glycol, carbon monoxide, and lead. All intoxicants level must be interpreted in conjunction with the history. Both urine drug of abuse screens and the more comprehensive drug screen vary widely in their ability to detect toxins and generally add little information to the clinical assessment, particularly if the agent is known and the patient's symptoms are consistent with that agent. Serum osmolality is only helpful as a surrogate marker for a toxic alcohol exposure. An electrocardiogram (ECG) is a quick and non-invasive bedside test that can yield important clues to diagnosis and prognosis. Abdominal X-ray is most helpful in screening for the presence of lead paint chips or other foreign bodies. Upper endoscopy may be useful for a prognosis after significant caustic ingestion. Further diagnostic testing is based on the differential diagnosis and pattern of presentation. Decontamination. Regardless of the decontamination method used, the efficacy of the intervention decreases with increasing time since exposure. Decontamination should not be routinely employed for every poison patient. Dermal and ocular decontamination begin with removal of the contaminated clothing and particulate matter, followed by flushing of the affected area with the tipped water or normal saline. A treating clinician should wear proper protective gear when performing irrigation. Flushing for a minimum of 10 to 20 minutes is recommended for most exposures although some chemicals, for example alkaline corrosives, require much longer period of flushing. Dermal decontamination, especially after exposure to adherent or lipophilic, for example organophosphate agent, should include thorough cleansing with soap and water. Water should not be used for decontamination after exposure to highly reactive agents such as elemental sodium, phosphorus, calcium oxide, and titanium tetrachloride. In inhalational exposure. Decontamination involves moving the patient to fresh air and administering supplemental oxygen if indicated. Preventing absorption, it includes activated charcoal, single or multiple doses, cathartic, whole bowel irrigation, enhancing excretion, emesis, gastric lavage, diuresis, dialysis, hemo, hemoperfusion. Gastric lavage. Gastric lavage involves placing a tube into the stomach to aspirate contents, followed by flushing with a liquid of fluid, usually water or normal saline. Although gastric lavage was used routinely for many years, objective data do not document or support clinical relevant efficacy. This is particularly true in children in whom only small bore tubes can be used. Lavage is a time-consuming and painful and can induce bradycardia via a vagal response to tube placement. It can delay administration of more definitive treatment, activated charcoal for example, and under the best circumstances only removes a fraction of gastric contents. Thus, in most clinical scenarios, the use of gastric lavage is no longer recommended. What is true today may not be true tomorrow. Activated charcoal decrease or prevent the intestinal absorption of a few drugs and toxins, as well as enhance the elimination of drugs already absorbed and present within the systemic circulation, especially prepared to have a very large absorbed surface area. Many but not all toxins are adsorbed onto its surface. Some toxins including heavy metals, iron, lithium, hydrocarbons, cyanide, and low molecular weight alcohol are not significantly bound to charcoal. Dose of 10 to 50 gram, about 1 gram per kg for a child is administered. Airway reflexes must be preserved or the airway protected by endotracheal intubation. It should only be considered for phenobarbital, thiophanate, phenytoin, carbamazepine, and dapsone poisoning. Cathartics, for example, sorbitol, magnesium sulfate, magnesium citrate, have been used in conjunction with activated charcoal to prevent constipation and accelerate evacuation of the charcoal toxin complex. There are no data demonstrating their value, and there are numerous reports of adverse effect from cathartics. Cathartics should be used with care in young children and should never be used in multiple doses because of the risk of dehydration and electrolyte imbalance. Whole bowel irrigation. Whole bowel irrigation involves installing large volume 35 ml per kg per hour in children or 1 to 2 liter per hour in adolescents for of a polyethylene glycol electrolyte solution, for example, Golitri, to wash out the entire gastrointestinal tract. Careful attention should be paid to assessment of the airway and abdominal exam before initiating whole bowel irrigation, which should never be given to a patient without bowel sound or with sign of obstruction or ileus or without protected airway. Intralipid emulsion therapy for sequestering fat soluble drugs and decreasing their impact at target organs. Specific toxidromes. Acetaminophen. The chief target organ of acetaminophen poisoning is the liver, with the kidney being involved in about 10 to 20% of those patients with hepatotoxicity. Rarely, nephrotoxicity may occur without significant hepatic involvement. The dose required to produce significant hepatotoxicity in adults is 7.5 to 10 gram. The commonly stated hepatotoxic dose for children is to be more than 200 milligram per kg. Stage 1, it is occurring in the first 24 hours. Early symptoms, mild serum acetaminophen level 4 hours post-ingestion, plot on specific nomogram. If more than 900 micromole per liter, we have a possible risk. Usual patient may develop nausea, vomiting, malaise, and diaphoresis. Normal bilirubin, transaminases, and PT. This is acetaminophen nomogram, which is very important because it is depend on time and the serum level of acetaminophen, because it is maybe no risk in one stage, but after a few hours maybe it is different. Stage 2, from 24 to 48 hours after ingestion, but the patient will be better, less symptoms, elevated bilirubin, transaminases, and P. In stage 3, usually from 3 to 5 days after ingestion, hepatic dysfunction, rarely hepatic failure, peak elevation in bilirubin, transaminases may reach more than 1000 international units per liter, prolonged PT, death or recovery. Stage 4, usually it is from 4 days to 2 weeks, the clinical improvement will start and liver function returning to. Probable toxicity should be treated with N-acetylcysteine, the bolus dose 140 mg per kg, then 70 mg per kg every 4 hours for 17 doses. Assess hepatic functions on presentation, daily, continue other support. Always remember, keep poisonous chemicals out of reach of children. Hydrocarbons. Determination of the risk of aspiration pneumonitis. First, low viscosity value such as kerosene, gasoline, lighter fluid, turpentine, mineral seal oil, and mineral spirits have the highest risk for aspiration. In contrast, more viscous hydrocarbons such as petroleum, lubricating oil, and paraffin represent a lower risk. Second, surface tension. A low surface tension chemicals has the ability to creep or spread along a surface. Third, volatility. Sorry. The more volatile the agent, the greater the likelihood for adverse central nervous system effect. The pathophysiology, these chemicals interfere with surfactant and directly irritate respiratory epithelium. The, result, the results are alveolar collapse, bronchospasm, direct damage to the airway epithelium and endothelium, and interstitial pneumonitis, resulting in ventilation perfusion mismatch, and hypoxemia and hypercapnia. Clinical presentation in kerosene poisoning. The GIT effect, burning sensation, nausea, belching, and diarrhea. Respiratory effect, cough, tachypnea, tachycardia, cyanosis, pulmonary crepitations, rhonchi, choking, gagging, and grunting. Chest X-ray, after more than 6 hours, it will show us pulmonary infiltrate or perihilar densities. Pneumatoceles usually occur 2 to 3 weeks after that. Pleural effusion or pneumothorax and bacterial superinfection rarely occur. Resolution usually take 2 to 7 days. Central nervous system effect may occur in at least a quarter of cases. Lethargy and much less often semi-coma, coma, and convulsions. Bone marrow toxicity and hemolysis are not common, but the clinician must be aware of the possibility of heart rhythm problems such as atrial fibrillation and ventricular fibrillation, hepatic and renal failure, skin and mucous membrane. Contact with the skin and the mucous membrane may cause variable degrees of irritation up to formation of bulli. Management: immediately remove the child from the source of the poisoning and ensure the airway is open. This is always the first priority. Remove the contaminated clothing and thoroughly wash the skin with soap and water. If possible, perform pulse oximetry and give supplemental oxygen if indicated. Intubation and mechanical ventilation may be needed in a patient with severe hypoxia, respiratory distress, or decreased consciousness. Avoid gastric lavage because of the risk of inhalation and hence pneumonitis. If very large amounts of kerosene have been ingested less than an hour earlier, then lavage may be considered if the airway can be protected by expert intubation. There is no evidence that corticosteroids are helpful. Some texts recommend the routine use of antibiotics, but this remains controversial. Admission to an intensive care unit is recommended for patients with early symptoms and signs of lower respiratory involvement because further deterioration of the respiratory function can be rapid. Important point: the vomiting should be discouraged because of risk of inhalation. Chest X-ray should not be done before 6 hours. No rule of gastric lavage because it may lead inhalation and pneumonitis. No rule of steroid, but antibiotics are controversial. Caustic or corrosive ingestion: the ingestion of strong alkalis or acids. The most commonly ingested alkalis is sodium hydroxide. The most commonly ingested acid are the hydrochloric, phosphoric, and sulfuric acid. They are found in acidic material in drain cleaners, rust removers, toilet bowl cleaners, tile cleaners. Alkaline material present in drain cleaners, oven cleaners. Serious injury associated with agent whose pH is more than 12 or less than 2. Acids denature protein, resulting in coagulation necrosis, while alkalis saponify fats and dissolve protein, resulting in liquefaction necrosis. Clinical presentation: the chief symptom is pain, which may be oral, thoracic, or abdominal, depending on the site of caustic injury. Young children may manifest pain by crying, drooling, refusing to swallow, and vomiting. Stridor or hoarseness usually indicates laryngeal injury. Rarely hematemesis or melena may occur. Examination may find evidence of dermatologic or ocular burns. The presence of oral or pharyngeal burns does not predict the presence of esophageal or gastric injury. Conversely, the absence of oral or pharyngeal burns does not preclude distal injury, particularly if a liquid alkali or acid has been ingested. Full thickness esophageal or gastric injury cause perforation of or subsequent fistula formation. The outcome for most children following corrosive ingestion is good. Superficial esophageal burns occur in 20% of cases. Deeper burns are seen in 5% of cases, and structure formation in 1 to 3%. Management: support of vital functions when these are threatened. Thorough removal of the product from the skin or eye by flushing with water. Activated charcoal, emesis, and lavage are contraindicated. Steroid or other signs of respiratory distress may suggest the need for potential intubation or surgical airway. Endoscopy can be performed within 12 to 24 hours of ingestion for prognostic and diagnostic purpose in symptomatic patient. The use of corticosteroids or prophylactic antibiotics is not beneficial. Attempt at neutralization of corrosive or gastric decontamination are best avoided. Always make sure that caps and tops are kept on bottle. Organophosphorus compounds. Organophosphorus compounds, insecticide, present in insecticide, inhibition, it will inhibit cholinesterase enzyme all over the body. There, so we will have muscarinic effect manifested by nausea, vomiting, abdominal pain, and fecal incontinence. Also, we will have cholinergic effect. It presents as cough, respiratory secretion, crepitation, and even pulmonary edema, cardiovascular, tachycardia, bradycardia, block, and hypotension. Nicotinic effect, restlessness, confusion, coma, meiosis, velocity, and convulsion. A clinical feature may be abbreviated by DUMPLES, defecation, urination, meiosis, block of the heart, bradycardia, emesis, lacrimation, and salivation. Diagnosis: blood cholinesterase level less than 50% indicate poisoning. Atropine as test dose. Management also ABC, airway, breathing, circulation, stabilization. Wash hair and body with soap and water. Consider gastric lavage if within 1 hour. Atropine sulfate IV till pupil are normal size. The dose of the atropine is 0.02 mg per kg every 15 to 20 minutes. Atropine sulfate IV till pupil are normal size. Remember, atropine has no effect on muscle paralysis. Must support breathing. Use cholinesterase reactivation such as pralidoxime, dose 1 gram per kg IV every 30 minutes. Prevention: the reduction in the incidence of childhood poisoning in the past half century has been dramatic, particularly among children younger than 5 years of age. The reduction is largely the result of the combination of highly effective active and passive method of intervention. Passive intervention, for example, introduction of child-resistant containers for drugs and other dangerous household products, and limited doses per container. Child-resistant containers have been particularly effective in reducing the incidence of death from the ingestion of prescription drugs by children. Active intervention, which require a change in behavior by parents and caretaker, include the safe storage of household products. Always we should remember, do not keep household cleaner in a low cupboard that children can reach. In summary, poisoning is exposure to a chemical or other agent that adversely affect functioning of an organism. ABC of toxicology: airway, breathing, circulation, drugs, draw blood, decontaminate, decontaminate exposure, examine full vital, fully monitoring, give specific antidote treatment. Acetaminophen poisoning mainly affect the liver. Kerosene poisoning mainly affect the respiratory system. Prevention of poisoning usually maintained by passive and active intervention.